it's regressive. The richer you are, and therefore the bigger your tax rate, the more of a tax break you get. So richer people are benefiting more from this than poor people. Finally, it induces excessive use of medical care, as through my flashing braces example, because people now are overinsured and therefore using medical care excessively. So clearly, every economist, okay, wants to get rid of this thing. Okay, unfortunately, we're kind of not that big a voting bloc. And unfortunately, it's easy. So I can describe this to you, and I hope you're all like, yeah, we should get rid of this. But now imagine the other side would say it. They'd say, they want to tax your benefits. This guy wants to tax your benefits. Oh, that's crazy. And I'll say to him, wait a second. No, actually, I'm getting rid of a tax subsidy to your benefits. And they'll say, shut up. You want to tax my benefits. And it's actually incredibly hard to make a good political case for this. I worked very hard trying to set a finance committee over the summer to actually start to scale back this tax exclusion. We weren't getting anywhere. Then our Senator John Kerry had a very clever idea. He said, let's call it instead a tax on insurance companies and not a tax on insurance plans. So we'll have what we call a Cadillac tax, which is any insurance plan that costs more than $23,000 a year. We'll have a tax on it. Now, you and I know, the economists know, that that'll just get passed on to the price of insurance. So really what it will mean is basically above $23,000, we're taking away your tax break. Because we're going to essentially, instead of doing the sensible thing, which is taking away a tax break, we're going to tax you to offset the tax break you get. But it'll have the same effect, and the economists will like it. And that's great. But once again, people then got very upset about that. And they're very upset about the fact that we're going to have this Cadillac tax that was going to raise $150 billion. Let me be clear. This Cadillac tax was going to raise $150 billion over the next decade. The tax exclusion over that same time period, we're going to lose $3 trillion. So we're talking about clawing back 5% of this enormous government tax break. People got irate, so it's been scaled back even further. Now it doesn't start till 2018. It only raises $30 billion over the next decade, but it raised a lot of money in the future. And that's a lot of why this bill is better and better for the deficit over time. This is a rare thing in Washington, that we're doing something which is an enormous new expenditure program, which at least some of us feel is doing good things, and reducing the deficit. That does not happen a lot in at the federal level, at least. So, second piece is reducing the deficit. Third issue is, what about cost control? Now, Barack Obama's not a stupid man. Okay? He knew, when he was running for president, that, quite frankly, the American public doesn't actually care that much about the uninsured. In fact, a lot of the uninsured don't care about the uninsured. They think they're young and healthy and don't need insurance. What the American public cares about is costs. And that's why, even though the bill that they're debating today is 90% about health insurance coverage and 10% about cost control, all you ever hear people talk about is cost control. How it's going to lower the cost of health care. That's all they talk about. Why? Because that's what people want to hear about. Because the majority of Americans care about health care costs. Now, what about health care costs? When we think about health care costs, you need to think about two separate things. This is complicated but very important. There's the level of costs and the growth rate of costs. So in other words, the level of costs today is about 17% of our national income. By 2075, if we do nothing, it will be about 40% of our national income. That is, every dollar that's earned in America, 40 cents will go to health care, okay, if we do nothing. That's a disaster. Okay? Now, let's say I said to you, I have a great plan that's going to get rid of all waste, fraud, and abuse in health care. By my estimate, the most that could be is 7 to 10% of our health care bill. Okay, that's the most that could be. So let's say we did that. Say we cut health care by 7 to 10%. That's amazing. That's huge. Well, you know what? Health care costs rise 7 to 10% a year. So all that means is that instead of spending 40% of GDP in 2075, we'll spend 40% of GDP in 2076. We're still going to go bankrupt. It's irrelevant. The level of healthcare costs is not what matters. It's the growth rate. The only way we're going to stop our country from becoming a latter-day Roman Empire and falling under its own weight is to get control of the growth rate of healthcare costs. The problem is we don't know how. Okay? We know sort of what causes high healthcare costs. I don't mean that. And any of you haven't read it, perhaps the greatest thing ever written in health economics is Atul Gawande's June 9, 2009 article in the New Yorker about McAllen, Texas, and excessive medical testing and medical utilization in McAllen, Texas. We know what the problem is. Our providers are paid enormously high. Look, in the 1950s, surgeons were middle-class guys like professors. Okay, they lived next door to professors. Now they live on the Hamptons and the Cape, and they have fancy, and they're like investment bankers. Okay, our providers are paid excessively, not the primary care providers, but the surgeons. We treat our patients much, much too intensively. Okay? Here's the tricky thing when comparing internationally. We don't actually go to the hospital more often. We don't see the doctor more often. It's just once the medical system gets its hands on us, it treats us incredibly more intensively. And this was what this Gawande article talks about, relative to the rest of the world. Now, let's be clear. You know what? It's worth it. Okay? Nothing frustrates me more than hearing people say, we spend the most in the world and yet we have the 32nd best healthcare system because look at our infant mortality rate. Okay? That's a crazy thing to say. Because the truth is, if you are an insured, wealthy person in America, there's no place else in the world that's better to get healthcare. And don't take my word for it. Let's look at what economists would look at, supply and demand. Okay? Every year, about 250,000 people come to America to get their health care from other countries. And about 12,000 people leave America to get health care somewhere else. Okay? If you're in Antarctica and you're equidistant from everywhere and you get sick and you have insurance, you're coming to America. We have the best health care if you're in the system. The reason we have such high infant mortality rates is we have the worst health care if you're not in the system. A black child born today in Washington, D.C. has less chance of seeing their first birthday than a child born in Jamaica. Okay? And that's what drives our high infant mortality rates. That's what drives our low life expectancy. It's not about the best of the health care. It's about the diversity and the fact that so many people don't access our health care system. So the problem is, if we just say, look, let's just cut our spending, well, the problem is you're going to then eat into what the rich guys are getting that they're liking, and that doesn't go so well. That's going to be pretty hard politically. That's why no one has a politically feasible way right now to bend the cost curve. It just doesn't exist. And we know what we could do. We could just cap costs. We could just announce tomorrow the U.S. government is spending more than 70% of GDP on health, and you wouldn't win very many elections taking that position. So what does this bill do? This bill takes what I call the spaghetti approach, which it takes a bunch of ideas that might work and throws them against the wall and we'll see what sticks. Okay? And basically, we don't know. I cannot guarantee you that the bill that's now being considered will bend the cost curve. I can guarantee you we'll be a heck of a lot closer if this bill passes than if it doesn't. Because it's going to try everything we know that might work. So, for example, the Cadillac tax might work. By getting people to buy less expensive health insurance plans, that might get people to use less health care. That might work. Economists think it'll work. Non-economists don't. We'll see. The bill also sets up a Medicare advisory panel that would try to depoliticize the rate setting for the Medicare program so that people aren't setting high rates to get votes, but rather setting rates that are appropriate to delivery of medical care. Might work, might not. The bill has 27 pilots of radically different ways of setting up our healthcare system, from setting up things called accountable care organizations, where doctors and hospitals work together and share both the risk and the return to patient treatment, to rates reimbursement that's tied to hospital readmissions and other bad indicators. 27 different pilots to try these different things and see what works. Maybe none of them will, but it's hard for me to believe none of them will. Some of them probably will. And once they work, the bill sets up a new Center for Innovation in the Center for Medicare and Medicaid Services to learn from these pilots and take what works and apply them nationally. Okay? And finally, the bill fixes perhaps the biggest flaw in our healthcare system. We spend 17% of our nation's income on healthcare, and we have no freaking idea what works. I mean, just think about that. We don't know, for most of the medical stuff we do, if it's better than something else you could do. We have incredibly little comparative effectiveness studies in the U.S. The bill finances and sets up centers to actually study comparative effectiveness. Now, we're never going to control healthcare costs unless we're willing to tell people they can't have the ineffective stuff. We're not there yet. But at least once we know it's in our face what's ineffective, then maybe we'll be more willing to actually take the steps necessary to control healthcare costs. Once again, none of these can I promise you will bend the cost curve. I can promise you that relative to doing nothing, it's a lot better to try all of these than just leave the system alone and let it spiral out of control till we're the Roman Empire. So basically, that's sort of where the bill is on cost control. I think the last thing I just want to say is when evaluating a bill like this, it is very important to choose your counterfactual appropriately. The counterfactual is not the world we'd like to have. The counterfactual is the world we're going to have without this bill. The counterfactual is not a world where we don't go bankrupt with healthcare costs. The counterfactual is a world where we do. So if this bill helps a bit, that's better than nothing. Okay, if it helps a lot, that's way better than nothing. But a lot of the trouble we get into in this bill, and people always want to pitch things the way they want to, is to compare not to what will happen without the bill, but some counterfactual world we'd like to see. And it's very important to remember where we're heading without the bill, which is 55 million uninsured people and healthcare at 40% of GDP. If the bill can help on either or both of those, then that's why I support it. So let me stop there and be happy to take your questions or comments.